and welcome to the Twin Sister Docs Podcast. I am Dr. Elaina McDonald, Board Certified General Pediatrician. And I am Dr. Delina Wardlaw, Board Certified Family Medicine Physician. Today, we are going to continue to discuss cancer awareness and prevention. So when we left off, Dr. McDonald, we previously talked about breast cancer, colon cancer. And so now we're going to talk about prostate cancer. All right, so Dr. Wardlaw, what is the prostate? Let's start off there. So the prostate is a small gland. It's about a walnut-sized gland that sits between the bladder and the rectum. And biological men have a prostate. Biological women do not have a prostate. And the prostate, it's a small gland, and it is used to help, it produces some seminal fluid to help move the semen along. And it can unfortunately develop cancer. Dr. Wardlaw, how do we screen or detect prostate cancer? So there are not a variety of ways. There are a couple of ways that prostate cancer can be screened for. One is a PSA test, or the prostate specific antigen test, a blood test that the doctor will draw, and we're looking for the level to be elevated. Now, an elevated level does not necessarily mean prostate cancer, although it could indicate, and it does mean you have to get a further evaluation, but it also could mean that the prostate is big or swollen or enlarged. The prostate, it could be inflamed, it could be infected, or a cancer is also on the list of things that is of concern. The other way to check for the prostate is the dreaded digital rectal exam. Again, the prostate is between the bladder and the rectum, so when you go and do the prostate exam, you do it through the rectum. The finger is inserted through the rectum, and the prostate is felt to see if it's soft, if it's hard, if it's boggy, if there's a nozzle there, if there's a lump there, and if it's tender, if it causes pain when you do the exam.
So you're looking for changes in that prostate.
Yes, and so when the exam is done, it takes about 5 seconds. Yes, many people complain they don't want to get it done, but it gives us necessary information. And if your doctor recommends that you get that test done, yes, you need to strongly think about that, because guess what? Think of a 5-second test versus if you get prostate cancer that goes undiagnosed, and now you got to get surgery there. You got to possibly get radiation treatment there. So again, now we have other issues that we need to be concerned about than a 5 seconds.
Yes, not 5 minutes.
5 seconds. 1, 2, 3, 4, 5. So please, if it's recommended, please make sure you get it done. Now, those tests do not give a definitive diagnosis of cancer. And so if your PSA is abnormal or if your prostate exam is abnormal, then you have to see the urologist, because your primary care physician, your family medicine physician, or your internal medicine doctor may do the rectal exam, or your urologist. Urologist is the prostate specialist, do the prostate exam. And if there are some suspicions, then a biopsy is typically the next step. Again, you have these conversations with your doctor and for specifics, but the specific tissue diagnosis, which is through a biopsy, gives the definitive diagnosis to say if it's cancer or if it's not cancer. So there are a few things that can be done to evaluate your prostate. You could get the blood work drawn, but the blood work can be elevated for many reasons. As the PSS says, the PSA can be elevated for many reasons. And the digital rectal exam, yes, we know you don't like it, but again, there are some things we have to do to make sure that we are living our healthiest, best lives. Yes. And so those things, again, can you'll have that conversation and decide what's recommended for you. Your doctor determines what is the best evaluation for you. Now, signs and symptoms that you could be having something going on with your prostate. Urinating throughout the night. You're getting up multiple times throughout the night. Now, having a prostate issue is not the only thing that could do that. You can have a urinary tract infection, you can have diabetes. So these things have to be evaluated, but that is on our radar if a male patient comes in and says, hey, I'm up all throughout the night. Now, if you're drinking 2 gallons of water before you go to bed, that's going to obviously cause you to get up in the middle of the night. But so be mindful of that and restrict if you're going to the bathroom a lot, you think about restricting your fluids if you're drinking a lot before you go to bed. But that is a warning sign. Also, if you're having, blood in your urine or blood in your semen, if you're having hesitancy with your urine stream, if it's difficult for you to go to the restroom, if it's difficult for you to pass your urine, if your urine is, if it's a weakened stream, if it's a hesitant stream, these are things that you need to talk to your doctor about and make them aware of these symptoms so that you can get the proper evaluation.
And when you say hesitant stream,
yes,
clarify what you mean when you say hesitant stream, Dr. Ward.
When you go to the bathroom and urinate, you should just be able to urinate. You shouldn't have to try to force the urine out. It shouldn't be a task for you to be able to go to the bathroom and pass your urine. So if there is some hesitancy with you being able to pass the urine.
So if you're having a hesitancy, that at least requires a discussion with your doctor.
With your doctor, yes.
All right. So prostate cancer, Dr. Wardlaw, how does it impact different ethnic groups?
So prostate cancer is, sometimes it could be a slow growing cancer. Sometimes it could be an aggressive cancer. Unfortunately, African Americans have a higher risk of prostate cancer and more aggressive of cancers. Prostate cancer, your risk factor for prostate cancer, one include, well, of course, being a male, 2, your age, and 3, your family history. So again,
know your family history. We need to discuss family history. There are some things that stays in the house, but family history needs to be discussed.
And so, Dr. McDonald, we have this conversation all the time. Growing up, people be, I don't want
what goes on in this house stays in this house.
And don't discuss my business with anybody. So-and-so don't need to know my business. People need to know your family history, okay? Yeah. Because that can impact their medical history. So please.
Your family members need to know your family history because, again, to Dr. Wardlaw's point, it can directly impact their medical history.
Yes, so please have the conversation today if you haven't done so already.
You don't necessarily have to do it at Thanksgiving. You don't necessarily have to do it at someone's first birthday party or anniversary party, but you do want to make sure you're taking an opportunity so that everyone knows what's going on in their family, because as physicians, we always ask family history because it is important to us.
Yes. Now, if a prostate cancer is diagnosed, we have it does not necessarily mean that somebody's automatically going to need to get surgery and or chemotherapy or radiation treatment. So there are options that are available depending upon the stage of the cancer, when the cancer was diagnosed. And so sometimes the cancer is deemed to be a very slow growing prostate cancer, and you'll have a conversation with your doctor and the decision will be made to, what we do is surveillance or aggressive monitoring, where they'll monitor the lab levels. They'll monitor the, you'll have biopsies every so often, or they'll monitor your imaging studies.
And to clarify, that's not, if it's a prostate cancer, they continue to monitor it, or they go in and they treat it, or if it's just an enlarged prostate, where they monitor it aggressively.
Well, so you can have a prostate cancer that can be monitored without going in and treating with surgery and or chemotherapy, but you have to have aggressive surveillance or aggressive monitoring. So you have to be following up with your prostate doctor, whether it's every 6 months or however often they tell you to come back, so that you can get those monitoring tests done, the labs, the imaging studies, if you need another necessary biopsy. So those things have to be, discussed. And those decisions, if you make a decision to do monitoring, that doesn't have to be the permanent decision. Those things can change later on down the line.
Depending on how your evaluation changes. When you follow up with your doctor, the key point here is making sure that you are following up with your doctor as instructed. You cannot let these things fall off the radar.
Yes, because again, some cancers could be monitored, very monitored aggressively. Some cancers may be, the discussion could be to have the prostate removed, or the discussion could be have the prostate removed and or have radiation or chemotherapy. So those are all discussions that need to be had. Follow-up is recommended, and we have to make sure that those things are happening.
All right. So as we move on from prostate cancer, Dr. Wardlaw, let's discuss lung cancer. Yes. So lung cancer and lung cancer, we see it in patients who smoke, and we say it time and time again. If you smoke, quit. For the younger people watching this podcast, do not start. Do not start smoking in any form, whether it is cigarettes, whether it is vaping, marijuana, whether it is vaping, whether it is these electronic cigarettes. Please do not start. Yes. Okay. But we also see lung cancer in people who don't smoke. Mm-hmm. And so we're seeing increasing rates of that as well. But we do have screening tests for lung cancer as well. And so who should be screened and when should that screening occur, Dr.
So if you're over, the screening is a CT scan. It's a CAT scan of the chest, a low dose CT scan of the chest. And the recommendations are if you're over the age of 50 and you've been smoking, you have a pack year history. Now, the pack year history, let's talk about that.
Yes, please explain the pack year history.
Let's talk about that. So, the pack year history. So, if you smoke 1 pack a day for 10 years, then you have a 10-year pack history.
Okay.
If you smoke 2 packs a day for 10 years, now you have a 20-year pack history. If you smoke a half a pack a day for 10 years, now you have a 5-year pack history. And for those patients who have a 20-year pack history, over the age of 50, currently smoke and or have quit smoking within the last 15 years, a CT scan of the lung is recommended.
Okay, there's specific parameters that you fall into before you are recommended to get a CAT scan of the chest to screen for lung cancer.
Yes. And again, that's the screening test for lung cancer. Now, if you go into your doctor and you're having some symptoms prior to the age of 50 and there is a concern, and so that, you may get the test before. You may get the test beforehand.
So what symptoms should we be concerned about, Dr. Wardlaw?
If you're having unexplained weight loss, if you're coughing up blood, if you are having your significant difficulty breathing, you're having changes on your lung exam, your chest x-ray shows some abnormalities that need to be followed up. So there are some things that definitely need to be
certain symptoms and signs that may indicate whether or not you need to get an
evaluation done sooner.
Further imaging and evaluation done sooner.
Yes. So lung cancer is, I feel like that is one that kind of the screening is not talked about as much, but it is very important that we provide those services to our patients and make sure that they are aware of that. And so that we can get it diagnosed earlier if we can.
Right.
Now, for those of us who smoke, Dr. McDonald, I just can't impress upon it again. And I'm going to keep saying it. Smoking has no benefit to us at all. At all. And listen, we understand. I've talked to plenty of my patients' parents. I've talked to some of my own patients who stress how difficult it is to quit smoking. We certainly understand that. On average, your average patient, how many times does it take them to try before they actually are successful with quitting smoking? That's about 7 times. So if you're quitting, you're not successful, keep giving it the old college try. You just have to keep giving it the old college try. And we have different things that we can use to help you quit smoking. You hear cold turkey, where you just stop smoking, right? But cold turkey it works for some people, does not work for others. We do have what we call nicotine replacement therapy, where we give you smaller doses of nicotine and then we decrease it so that your body can get used to those smaller doses of nicotine, so that when you stop using the replacement therapy, whether it's a patch, whether it's a gum, whether it's an inhaler, many people may have heard of these things. Once you stop, your body is used to such a low rate of the nicotine that you don't have those cravings and those withdrawals.
Right.
Also, we have medications that we can use. It's not nicotine replacement, but it works on your pleasure center in your brain, where it decreases your cravings and your withdrawal symptoms from the cigarettes.
Right. So we do have things that can help, but this is very much, you have got to be prepared. Right. The medication alone is not going to do it. The patches alone is not going to do it. You have to be prepared. So you have to, one, pick a stop date. I'm going to quit smoking on Mother's Day, March 1st, my birthday. So you have to pick a date. When that date comes, get rid of the cigarettes. It cannot be, I'm going to quit smoking when I get to the end of this pack. And then the pack never comes. So you have to make a debt. You have to be mentally prepared. You got to get rid of all your ashtrays, your lighters. You have to be able to make sure that you have something to do with your hands during the times that you're most likely to smoke. So if it's when you first get up in the morning, if it's after dinner, if it's during your work break, make sure that you are doing things to occupy your hands. Some people have taken up knitting. Some people do crossword puzzle. Some people get on their phone and, play a game or do something to that nature to occupy their hands, because that smoking, that habit of constantly putting something in your mouth. Yes. You need to try to replace that with something else if you're going to be successful. So we know quitting smoking is hard. Again, if you don't smoke, please don't start. But if you do, we know it's not going to be easy, but there are things out there to help you. And if you aren't successful the first time, try again and again and again, because we do know the benefits start to kick in once you stop smoking. Yes, and speaking of those benefits, you can start seeing benefits immediately. And within 20 minutes, your heart rate can start to decrease from, not having a cigarette, and then over, 2 to 3 months of time, you can notice that old smoker's call starts to decrease. Within 5 years, you'll notice that you may not notice, but the physician, yes, your physician will notice that your risk of a stroke compared to a person who smokes has decreased by half. And year 15, your risk of heart disease is comparable to that of a non-smoker now. So yes, the benefits of smoking are zero. Huge. So the benefits is zero. I'm sorry, I take that back. The benefits of quitting smoking. Yes. Let me correct myself, Dr. McDonald. The benefits of quitting smoking is monumental. Yes. Huge. There are no benefits to smoking. Zero. Yes. I say it again. Zero. Yes. Yes. So with that, we are now going to move on to cervical cancer, Dr. Wardlaw. So one, we need to clarify where the cervix is. Yes. And then we could discuss cervical, how do we prevent cervical cancer? So the cervix is for biological females, women who are born as women. We have a reproductive organ called the uterus, and that's also known as the womb. Is a layman term. Where the baby grows, where the baby lives, and so the opening to the uterus is called the cervix, and the cervix, unfortunately, can develop cancer as well. Now, the way we screen for cervical cancer is a test called the Pap smear. So when you go to your family medicine doctor, or you go to your GYN and they do your GYN visit and they do the Pap smear, they take a little brush and take a swab to get some cells, send it off to the lab, and to see if there are any cells that are starting to change their appearance, that we become concerned that it could be precancerous, or sometimes you get in, unfortunately, it's cancerous. But the Pap smear is the preventive study that we do for that. We start that at age 21. Okay. 21. That's a change. Yes, because many of our more mature populations, we started Pap smears at the age of sexual activity. That is no longer the case. Right. We start the Pap smear at age 21 years of age. The old adage, you got to go to the doctors to get your Pap smear. We're not doing that to the age of 21. Right. Now, that doesn't mean that we're not checking for sexually transmitted diseases, and if you're having problems with your period, your cycle or your menstrual cycle, that you may be referred to the GYN if you're having those issues. But we're absolutely checking those things as well. But it's the screening test that starts at a certain age. Yes. I also want to be clear, Dr. McDonald.
Pap smears are not done in the emergency room. Many patients were under the impression that if they go to the emergency room for vaginal bleeding or a vaginal discharge or pelvic pain, that the emergency room is doing a pap smear. Emergency room, they do not do pap smears. They are checking for any types of infections, any abnormal growths, masses, anything of that nature. But so not a pap smear. So you have to follow up with your regular doctor, whether it's your family doctor or whether it is your GYN to get the pap smear.
So pap smear is done on an outpatient basis.
Yes.
It is not done in the emergency room.
And it's not done in the
urgent cares.
Yes.
It is done in your primary care doctor's office.
Yes. Yes. Or your GYN doctor's office. So, and there are many patients who will come in and say, I'll say, when was your last pap smear? And they'll say, oh, why pap smear? I had one in the emergency room. ER does not do pap smears.
Right. Okay. So pap smear 21 years of age.
Mm-hmm.
And then is there a recommendation for how often you should get a pap smear done?
And again, so those recommendations too, there's not a definitive recommendation, but it could be 3 years, it could be 5 years, depending upon your age, depending upon if HPV was detected, and then we'll talk about that in a second. Yes. So previously, medicine is always evolving.
Yes.
We're always learning. And so previously would be you have to get a pap smear every year. Right. That is not the case any longer. Now, your doctor may still recommend, hey, you come back in a year, you may come back, but it could be you come back in 3 years.
Right.
It could be you come back in 5 years, but that is a discussion
with your doctor.
With your doctor.
Again, you will always hear Dr. Warlar and I say, you must have a discussion with your doctor, because while there are general recommendations, certain recommendations may change based on what is going on with you specifically.
Yes. And so that's cervical cancer. Now, we also have prevention measures for cervical cancer. So we talked about the pap smear, where we can detect the cells early, where they're changing in early stages. If there's a concern, we could do additional testing. We can have the cells removed. Your doctor may recommend, you need to get a colposcopy, yes, which is a test where they do an examination, a closer examination of the cervix. They use a special scope. They do a special examination to look at the cells.
Okay.
And then there may be another procedure that's recommended from there. Where they may recommend that the cells are removed, the LEAP procedure. Or maybe you may go in and unfortunately the pap smear may come back that it's cervical cancer. And you have to get surgery or you have to get further treatment. You have to talk to the cancer doctor who is the oncologist. So there's a process. But in general,
21.
Pap smear start at age 21.
Now, Dr. Wartlaw, let's move on to how we can prevent cervical cancer.
So we do know that we have a vaccine that helps protect against strains of HPV that can lead to cervical cancer.
And HPV is the human papillomavirus.
And so, Dr. McDonald, can you give us some insight into that? Because we started this vaccination at early ages.
Yes. Mm-hmm. So cervical cancer, yes, we have a vaccine. The name of the vaccine is called Gardasil, and it is protect against cervical cancer. Most cases of cervical cancer develop from certain strains of the human papillomavirus. Many strains of the human papillomavirus, if your immune system is working properly, will resolve on its own. But we do know that there are particular strains of human papillomavirus that can lead to cervical cancer. That is why a vaccine has been developed to prevent the development of the cervical cancer from that virus. Again, the virus is called Gardasil. It's called Gardasil 9.
The vaccine is called Gardasil.
Sorry, yes, the vaccine is called Gardasil 9. And it's to protect against 9 particular strains of the human papillomavirus that we know can lead to cervical cancer, can also lead to vaginal cancer. So we have a very preventable way to prevent cervical cancer. You can start the vaccine as early as 9 years of age. Some people say, why do we start the vaccine so early? Well, one, we know that the human papillomavirus, once you become sexually active, then you can transmit the human papillomavirus amongst one another. But the earlier you give the vaccine, the greater response your immune system has. So originally, the human papilloma virus vaccine, or Gardasil, it was 3 doses. But again, as Dr. Wardlaw has previously mentioned, we're constantly doing research in medicine. So now the studies have shown if you give the vaccine earlier, before 15 years of age, then you only need 2 doses because your immune system has a greater response. If you start the Gardasil vaccine after 15 years of age, you need 3 doses. So again, with research, we know the earlier you get it, the more the greater response of your immune system. So the vaccine has been out for 20 years. So we do know that it's a safe vaccine. It is effective. Again, as we talk about vaccines, we know that it has been through rigorous clinical trials. The benefit outweighs the risk. Again, and my practice is we start the vaccine at 11 years of age. Again, you can give it as early as 9, but we start the vaccine at 11 years of age, and we discuss it with all of our families. We recommend it to all of our teenage girls. And actually, Gardasil is for boys also.
So let's talk about that, Dr. McDonald, because I want to address that Gardasil, the HPV vaccine, protects against the HPV virus, which is directly related with cervical cancer, but it's also related with some other cancers as well. Throat cancers, pharyngeal cancer. So we want to make sure that
rectal cancer,
so that these are cancers that we are trying, if we can do anything to prevent it, we really need to do that. And so, yes, only girls have a cervix, but we know that HPV can affect other areas aside from the cervix as well. What we just mentioned, the rectum area, the throat area. So we have to make sure that we are being educated on for males, for boys and girls.
So we recommend the vaccine for males and females in our practice. So this is a vaccine that everyone is recommended that they get starting. Again, you can start as early as 9 based on CDC recommendations, but we start at 11 years of age in our practice. So our males and our females, we recommend this vaccine.
So Dr. McDonald, we hear concerns from individuals, and one of the concerns is, I heard that someone could pass out if they get that vaccine.
So with the Gardasil vaccine, there have been some instances where within the first 15 minutes after getting the vaccine, someone can faint. So we usually recommend, once you get the vaccine, we observe your 15 minutes, if you have not had any fainting within those first 15 minutes, you're unlikely to have any issues after that. And again, that's only a very small number of patients. We give out the Gardasil vaccine to hundreds of patients or thousands of patients in our practices every year. So, and we only see that fainting maybe once or twice. So, but you can sometimes see that.
And so we put parameters in place where you get your HPV vaccine, and you should sit for 15 minutes before you leave the office. So you can't just get your vaccine and try to run right out the door. Again, a very, very small risk, but again, the benefits far outweigh that risk, and that also you can get the common vaccine side effects
at the site and redness at the site, but again, those will go away within a couple of days.
Yeah. Cervical cancer is, again,
we have a vaccine to prevent it, and we also have a test to screen very early to diagnose, detect early on. So please talk with your doctors about the HPV vaccine. And make sure that you are talking with your physician about the pap smear if you are 21 years or older.
Now, in this episode, we've talked about prostate.
Yes.
We've talked about lung. And we've talked about cervical cancer. Now, these things we have screening tests for, in addition to also like breast cancer and colon cancer. But there are some cancers that we hear about, and many of the times when the diagnosis comes, it's a late diagnosis. And reason for that is, some of the reason for that is that we don't have a screening test
that we start at a certain age, no matter what.
We don't have a screening test where we are looking for the cancer before signs or symptoms develop. And so many times that puts us behind the eight ball when a patient presents. Pancreatic cancer is one of those cancers. Ovarian cancer is another cancer where we don't have the ability to detect it early. And so this is why research is so important.
Yes.
Research is what drives the advancements in medicine. And so hopefully we will get to that stage where we have a screen and test for these other cancers as well. But for right now, our hands are tied because we don't have the ability to screen before
The symptoms begin.
the symptoms begin.
But as we always say, if you are having symptoms, signs that are abnormal, please reach out to your doctor to determine what the next appropriate step is.
And so we talked about the screening things that you could do, but other things that you can do to help decrease your risk of cancer. One, making sure you get a proper diet. Two, really trying to avoid these ultra processed foods, that these quick foods that we could,
Pop in the microwave, put in the air fryer.
yes, the prepackaged foods, so we have to make sure that we are being very mindful of that. Again, some things we can control, some things we can't control, making sure we get exercise, which we'll talk more about that in another episode. But again, quitting smoking, which we said 11 times, and we will say 11 more times.
If you smoke, stop. If you don't smoke, please don't start.
So those are things that you can do on your behalf. And discuss family histories, please. Please discuss family histories.
Very, very, very important. So thank you for tuning in to this episode of the Twin Sister Docs podcast.
We'll see you in the next episode.